Uh, Thank you. First of all, I would like to thank the International Cancer Conference organizers for inviting me to present our work. So I'm going to talk about the genomic analysis of circulating cell-free DNA in follicular lymphoma with a diagnostic, prognostic, and therapeutic perspective today. Many cancer researchers are working in the field of carcinomas. However, our research group focuses on lymphoid cancers, as you can see here. So these constitute 4% of all cancers, and they derive from B, T, or NK lymphocytes. There are different type of categories actually in this lymphoid cancer group. The biggest category is non-Hodgkin lymphoma, which is by itself heterogeneous. It constitutes around more 62%. And this is also heterogeneous by itself, as you can see. The most common non-Hodgkin lymphoma is diffuse large B-cell lymphoma, and the second most common one is follicular lymphoma. And my topic today, our study that I will be presenting today, will be on follicular lymphoma. So what is follicular lymphoma? This is the most frequent indolent type of non-Hodgkin lymphoma. It occurs as a result of neoplastic transformation of germinal center B cells. As you can see, actually, most of the B-cell lymphomas, non-Hodgkin, both Hodgkin and non-Hodgkin lymphomas actually arise from the abnormalities in the germinal center tissue. One interesting feature of this type of cancer is that the patients can be symptomatic during diagnosis, but they may be also asymptomatic. Another important characteristic is the fact that although it is an indolent cancer, around 20% of the FR cases, we see the progressive disease or relapse. Some of the follicular lymphoma cases can undergo histological transformation to more aggressive B-cell lymphoma, such as diffuse large B-cell lymphoma. Before we start our study, the genetic landscape of follicular lymphoma was already established well due to the development of next generation sequencing methodologies. Previously, also there were some Sanger sequencing based mutation analysis, and many genes mutated in this lymphoma, in the tumors of this lymphoma, have been identified, and most frequently mutated ones are BCL2 lysine methyltransferase 2D, CREB-BP, ZH2, EP300. As you can see, most of these genes are actually epigenetic regulatory genes, so they have also pathogenetic alterations in follicular lymphoma. So this is just one important study about the mutations in follicular lymphoma tumors. As you can see, what they did in the study is to do a target NGS of 28 genes, and they identified many genes, such as lysine methyltransferase 2D, CREB-BP, ZH2, to be frequently mutated in follicular lymphoma tumors. Not only epigenetic regulators, also JAK-STAT signaling pathways, BCR and kappa B signaling members have found to be mutated. Now, as you know from carcinomas, one of the biggest problems during diagnosis, especially also staging and prognostication, is the fact that we need to take the standard biopsy using surgical procedures. This is the gold standard in order to have a diagnosis, definite diagnosis. Most of the time, actually, tumor tissue characterizations are needed, but they have certain disadvantages. For example, the patient may feel pain, the area may have infection, and also anatomically, it may be difficult to obtain some of the tumor tissues because of the different anatomical site the tumor tissue is present in the patient. And the biopsy sample also may not reflect the heterogeneity of the tumor tissue or different tumors in the patient. What I mean generally is the genetic heterogeneity, but this may be also related with the expression of the certain markers of the on the cell. So also the disease is difficult to monitor regularly, and this is especially important to predict, for example, relapse or therapy response. So in order to overcome these problems, nowadays investigators are focusing on liquid biopsy as an option to replace this histologic biopsy. Especially circulating cell-free DNAs are important study research area these days in cancer. These cfDNAs actually are small fragments of DNA that's found in the plasma of everybody, not only in cancer patients. And sometimes there is circulating tumor DNA also. It was shown in other cancer types that the DNA pieces that's coming from cells, if there's a cancer, if it's a cancer patient, there will be mixture of the normal and the tumor DNA in the blood. And these are generally 150 base pair length fragments of DNA. So you can see they can derive from apoptotic cells, necrotic cells, or through secretion as exosomal DNAs. And point mutations, translocations, or other genetic or epigenetic aberrations can be found in this circulating cell-free DNA. In cancer patients, it's proposed that the ctDNA reflects the tumor tissue genetic and epigenetic alterations. So with this background information, we hypothesized that plasma of follicular lymphoma patients contains circulating tumor DNA that can be used to improve diagnosis and prognostication. Our first aim is to investigate the presence of cancer-derived mutations in circulating cell-free DNA obtained from treatment-naive follicular lymphoma case using a targeted ultra-deep sequencing. So we chose the next-generation sequencing approach, targeted approach in this study. And the second aim is to examine the degree by which cfDNA and tumor DNA contain common somatic mutations. And the third aim is to evaluate whether somatic mutations detected in the cfDNA and or tumor tissue DNA can predict the prognosis of follicular lymphoma patients. So this is the basic workflow of our study. We included 20 follicular lymphoma treatment-naive follicular lymphoma cases. We obtained the tumor tissue and peripheral blood from these cases, and isolated the tumor tissue DNA and separated the plasma part and the rest of the peripheral blood, and we isolated cfDNA, and also we isolated the granulocyte genomic DNA. After that, we performed ultra-deep targeted next-generation sequencing using 150 follicular lymphoma-associated gene exons and exon-intron junction sites. And we did variant analysis. We filtered the germline single nucleotide polymorphism. That's why we had the granulocyte genomic DNA from patient match as the patient match sample. And we identified the somatic variants. So these are the list of the 110 genes actually. We very carefully collected the list of genes based on previous publications on the follicular lymphoma tumor samples. They are mostly NGS. These mutated genes were identified through NGS mainly, but some of them were identified by Sanger sequencing as well. So I will not get into so much detail, but we used a very meticulous approach in order to identify the confident variant list. Important point I want to mention here is that we use a variant calling algorithm program called MUTEC2 that can identify the somatic variants with low fraction of variant array fractions. And we also focus our study on the cosmic annotated variants that are also implicated in hematological cancers. And we identified missense, nonsense, indels, and splice cell small mutations, and generate a confident variant list. Before presenting our results about the cfDNA genotyping in follicular lymphoma, I would like to briefly mention about the fact that we also measured the cfDNA concentration in the treatment-naive cases and observed that when the cfDNA concentration is high, both overall survival probability and also progression-free survival probability of the patients are significantly inferior compared to the low cfDNA concentration patients. As you can see in panel C, we also compared the symptomatic versus asymptomatic cases. You would remember from the beginning of the presentation, I mentioned that some cases are asymptomatic, some of them are symptomatic in terms of clinical symptoms in the patient. And we observed that the cfDNA concentration generally and significantly higher in the symptomatic case compared to asymptomatic ones. So these are the number of the number of the variants we identified in follicular lymphoma cases. Panel A is showing all cases. As I said, we had 20 follicular lymphoma cases. So in this Venn diagram, you can see that 33% of the mutations identified were common somatic mutations in both tumor tissue DNA and plasma circulating cfDNA. And that most of the variants were specific for actually tumor tissue DNA. And interestingly and importantly, some of them were only specific for plasma cfDNA. It means that they were not present in the tumor tissue DNA. Again, as you can see in panel B and C, we compared also the symptomatic versus asymptomatic FR cases. And we observed that there is a marked increase in the common list of variants, percentage of variants in symptomatic cases versus asymptomatic cases. So this graphic, waterfall graphic, is actually showing the mutations we identified either in tumor tissue DNA or circulating tumor DNA in patients, in FL patients. This was consistent with previously published literature, actually. The CREB-BP gene was the most highly mutated one, followed by the BCL2 mutations, which is observed in 30%. STAT6, EZH2, and CARD11 mutations were also common. And most of these mutations were missense mutations, but we observed nonsense mutations in them and other splice site mutations as well, rarely. Now, it's already known what kind of somatic alterations are present in follicular lymphoma tumors. So our aim was to show whether we can identify these as circulating tumor DNA or as circulating tumor DNA or not. And this is actually integrative genomic view, a screen view of one of the patients and one of the variants that we identified. It is lysine methyltransferase 2D, another name is MLR2. This is a nonsense mutation G2A mutation. And important part, there are two important parts. One of them is that previously exactly the same mutation was identified by others, Pascucci and colleagues. Not only, but it was observed in tumor tissue DNA. As you can see here, we not only identified this one in tumor tissue DNA, but also observed the same mutation in plasma, in the plasma of the same patient. And as you can see in the granulocyte, there is no mutation. So this is showing that this is a somatic mutation. Another important mutation I want to show is EZH2 Y646F mutation. This is an important mutation. I will come to that soon. Why is it important? This is actually a hotspot mutation in the EZH2 gene. As you can see, it's not only present in the tumor tissue DNA, it's also present in the plasma cfDNA. This is also single nucleotide change. It's a missense mutation. Now I'm only showing one of the Sanger sequencing validations we did, especially people, scientists working on the field of cfDNA genotyping knows that Sanger sequencing is probably not the best approach to do the cross-validation of the NGS results because of the sensitivity level, which is 20% variant error fraction. But when we did Sanger sequencing for all the variants which has at least 20% variant error fraction, we were able to predict and validate all of them 100%. I'm just showing one example here. Here, the gene is ARID1A. This is also a nonsense mutation, C to T. Left side is showing the NGS result. Right side is showing the forward and reverse sequencing of the Sanger sequencing result. So you can see that the formalin fixed paraffin embedded tumor tissue DNA variant error fraction was 34%. It was easier to validate the mutation. And the mutation, the same mutation in the cfDNA of the same patient was had 20% variant error fraction. But this was the borderline for Sanger detection actually. But we were able to show clearly both with forward and reverse sequencing that the same mutation is also present in the cfDNA of the patient. Another thing we did is the prognostic analysis of this based on these mutations, and we choose the recurrently mutated genes, and dichotomize the patients based on whether there's mutation or not. So then we did the overall and progression-free survival analysis and generate Kaplan-Meier plots. For all other genes we checked, we didn't see any association of mutations of each gene with the survival. However, we found a very interesting result with BCL2. When there's a small BCL2 mutation, there's the overall survival probability is lower. Also, progression-free survival probability is lower. And importantly, next, what we want to check is that let's suppose that we don't know any information, we don't have any information about the mutations in the tumor tissue DNA. If we only know the mutation status in the cfDNA, whether we can still have prognostic information or not. In fact, we get even better result with this survival analysis, that if we only check the BCL2 mutation status in the cfDNA and dichotomize the patients, then what we observed is that the mutated patients has inferior survival, both overall survival probability and the progression-free survival probability was significantly lower. For follicular lymphoma, there are some already established prognostic indicators that is already used in the clinic. So, for example, Ki-67 index, LDH values, and FDG, PET-CT positivity. So, in our cohort also, we check whether these poor prognostic indicators can predict the inferior prognosis or not. And as you can see, a high Ki-67 index, which is an indication of high proliferation, actually, a high LDH value, and a high high number of PET-CT positive regions were associated with poor survival. Then we combined BCL2 mutation status with each of these already established clinical variables in order to evaluate whether we can identify more higher risk or more lower risk patients or not. Indeed, when we check, as you can see in panel A, when we look at patients which has BCL2 mutation or high Ki-67 index, you can see that they had the worst survival probability, and this was also true for other variables, BCL2 mutation plus LDHT levels, or BCL2 mutation in cfDNA with the PET-CT positive region. So if BCL2 mutation is present and any of these variables also high, then we can even identify higher risk patients in theory, but of course it needs to be validated in larger cohorts because the number of cases were low in this study. Now I want to come back to EZH2 tyrosine 646 mutations again. So EZH2 is actually histone method transferase. It's a part of a repressive complex called polyconjugate complex that is involved in generation of histone 3 lysine 27 trimethyl marks. And this is associated with transcription repression, as you may already know. The set domain has the method transferase activity, and the 646 residue here shown in this located in the set domain has already been shown in different types of cancers to be mutated, and they are generally gain of function mutations. So when we look at our cases again, we observed that 15% of the FL cases has not only EZH2 mutation, but EZH2 mutation affecting the tyrosine 646 residue. There are also other mutations identified. So this is a general result, but at least 2 of these mutations were also identified in the cfDNA of the patient, not only in the tumor tissue DNA. EZH2 is especially important because it was already known and shown before in blood that they are frequent and represent an early event in follicular lymphoma, and they had also identified that 27% of the FL cases has mutations in either 646 or other hotspot points to be mutated. There is a Lancet Oncology paper that was actually presenting the results of an EZH2 inhibitor in relapsed or refractory B-cell non-Hodgkin lymphoma and advanced solid tumors. In other words, EZH2 inhibitors is already under development, and this may be an option for treatment of EZH2 mutation positive patients. Another interesting result associated with our study was the fact that some of the CFD mutations was only present in the CFDNA, not in the tumor tissue DNA. So this is a result from one of the FL cases. We observed BTG1, E450, and beta-2M, Q2M2 mutations. They are actually point mutations, and instance, and one of them, other one is nonsense. Another important point about these genes and the mutations is that they were already shown by others that they are associated with the early progression of histological transformation of follicular lymphoma. So and also this exactly the same mutations were already reported either in transformed follicular lymphoma or DLBCL. This is, I think this was de novo DLBCL, but sometimes transformed follicular lymphoma transformation may happen to DLBCL also. Another important point here is that this mutation was identified during follicular lymphoma stage before treatment, and this patient gets the treatment after 6 months, there's complete remission. 1 year after the therapy, there is a progression of the disease. So in conclusion, with this study, we identified many cancer-associated mutations in FL-CFDNA for the first time. Plasma CFDNA concentrations in FL can be used for non-invasive prognostication. Even if you don't have any information about the mutation profile, we can use the CFDNA concentrations to predict the poor prognosis. And also BCL2 mutations in FL-CFDNA can be used for non-invasive prognostication. We can just check the BCL2 mutation status in the CFDNA, and it has prognostic value. And also, it's also at least in theory possible that very high risk FL patient group can be identified by combining BCL2 mutation status with already established clinical variables. Not only this, we can also use these mutations identified in the FL-CFDNA to guide the therapy. For example, as I mentioned, FL cases with EZH2 gain of function mutations can be targeted by EZH2 inhibitors. For FL cases with BCL2 mutations may also be targeted by, for example, BHD mimetics. And also, finally, the plasma CFDNA genotyping may provide information on histological transformation of FL. We observed in one case these mutations in the CFDNA, but if it is true for other cases, this may provide very valuable information, because before the transformation of FL to aggressive B-cell lymphoma, it may be possible to do early intervention. So I would like to thank to our lab members, both current lab members and previous lab members, for contribution in the study. Also the hematologists and pathologists in the Dokuz Eylul University, Acıbadem University, Gazi University, and for computational help support provided by Tuğba and Sözek from Muller Koçman University. This study was supported by TÜBİTAK 101 project number is indicated here. I would like to thank them also for their financial support. With that, I would like to finish my presentation. Thanks for listening.
Thank you, Dr. Kucuk, for your